So in this video, we're going to be talking about spondylolosthesis. Now, spondylolosthesis is where you get one vertebra slipping either forwards or backwards relative to another vertebra. When we image the spine, what we expect to see is that all of the vertebrae are actually stacked up on top of each other in a very, very straight, uniform way. Now there will be a curve, but that curve is normal and you'd expect the curve to be like this. What you don't expect on an X-ray or an MRI scan is when the curve, then you get a step where there's a slip and then the spine continues. When we see a spondylolosthesis in clinic, we usually try to get that imaged because what we're feeling for is that the spine, when we're pressing into it, feels uniform all the way down. If a patient comes to us with an imaging of a spondylolosthesis, the first thing we want to know is actually how severe it is. Now that's done on something called a Meyer-Dings classification, and it goes from grade 1 to grade 5. Now a grade 1 spondylolosthesis is considered very mild and actually is very common in the population, and that means that the one vertebra has slipped on top of another by around about between 1 and 25%. And that 25% may seem a lot, but actually that's very, very common. Grade 2 is a slippage of between 25 to 50%. Grade 3 is between 50 to 75. Grade 4 is between 75 to 100%. And then grade 5 is over 100%, where the one vertebra is completely disattached to the other. And in that sense, you would expect a broken back or a fracture. So that's obviously the most serious, a grade 5 spondylolosthesis. And then we can actually classify them in a couple of other ways. You can get a dysplastic spondylolosthesis, which is basically congenital, you've been born with that. And then you can get an isthmic spondylolosthesis, which generally happens with younger people, perhaps under the age of 20. And you can tell that because the slippage tends to happen in the most bottom section of spine at L5 to S1. And then you can get the degenerative form of spondylolosthesis, which happens in older patients and usually happens in one joint above that at the junction of L4 to L5. And the final thing to say about spondylolosthesis is, by classification, is that they can either be retro, so one joint is slipped backwards relative to the other, or it can be levo, which means that or anterior, which means that it can be forward from one to the other. Now, when the treatment for that in all circumstances is if it's severe enough, perhaps a grade 5, that very well may need surgery because the spine has become unstable. But as long as the spine is still in some sense stable and there's some structural rigidity there, then surgery can be avoided in that sense. If surgery, and your consultant says surgery is avoided, then actually the purpose of exercise and rehabilitation is not actually to try to improve the structure of the spine. So exercise isn't going to take a grade 3 spondylolosthesis and actually return it to a grade 1 or no spondylolosthesis. But what it is trying to do is improve the function, so your day-to-day tasks become less painful, you're able to bend and you twist and go back to activities with no pain. But more importantly, the improvement through exercise and rehabilitation of the structure and function of the spine actually ensures that you actually guard against deterioration, so that in future your grade 2 spondylolosthesis doesn't progress to grade 3 or, heaven forbid, a grade 4. And the way that that's achieved in clinic is what we're looking to do is firstly switch on all the muscles that have governance over that area of the spine. So all the little muscles, multifidi, intratransversari, longissimus, all those guys that aren't doing a good enough job in stabilizing the spine, we need to get nice and strong again. And then once we've ensured that the brain can adequately control the muscles in the spine, we then to start you on an intensive rehabilitation program, trying to stabilize the spine through activity, stabilize it through strength training in order to get that stability back, to ensure that that spondylolosthesis doesn't progress any further.